On Cracking Addiction today, we discuss benzodiazepines, their role in cognitive impairment, addiction, alcohol withdrawal, and we discuss benzodiazepine tapering. So we're now going to talk about further issues with benzodiazepines, and we'll start off with cognitive function. So benzodiazepines impair cognitive function, right? So yes, everyone loves them because they're useful for the management of anxiety symptoms in the short term. But they are a depressant drug. All of them depress CNS function. They impair cognitive function. So in the acute stages, the use of benzodiazepines can actually cause anterograde amnesia. So that means that from the moment that you take the drug, you have no further memory of events that occur after taking the drug. And that is why some benzodiazepines, the short-acting ones, have been used as date rape drugs. The use of benzodiazepines in the short term also impairs the acquisition of new learning because you can't focus, you can't memorize, and they are sedative. So we need to understand their effects on attention and concentration. So that further impairs acute cognitive function. In the longer term, now I'm talking about use for more than 6 months. In the longer term, we are talking about impairments in concentration, psychomotor function, so the inability to use tools and instruments, impaired learning, so the impaired ability to benefit from group work if you're trying to actually come off benzodiazepines, impaired visuospatial skills, so impaired hand-eye coordination, impaired driving. In fact, you're 5 times more likely to be in a motor vehicle crash if you are using long-term benzodiazepines. Now, the impairment can actually last for 6 months after cessation. So you might have stopped benzodiazepines, but you've still got this chronic impairment in these domains of function. You pay a high price for using benzodiazepines. And I think people underestimate this. It's a very high price. And as an addiction specialist, my biggest concern with benzodiazepine use is actually benzodiazepine addiction. And the addiction potential is related to the speed of onset of the drug and what I term the euphorogenicity of the drug, i.e. how high do you get after using the benzodiazepines. And benzos act on GABA-A receptors as we've already discussed in previous episodes. And GABA-A receptors in the ventral tegmental area can actually release a surge of dopamine. And so that's why benzodiazepines become addictive, because they actually cause a secondary release of dopamine actually downstream in the nucleus accumbens. So if we're thinking about the liability for addiction in terms of euphorogenicity and speed of onset, so the benzodiazepines with the highest liability for addiction include flunitrazepam rohypnol, diazepam, Valium, alprazolam, Xanax, lorazepam, Ativan. And you tend to get lower risks of addiction liability with clonazepam, Rivitrol, chlordiazepoxide, Librium, and oxazepam, Seropax. So the good old Xannies that people use for panic disorder and generalized anxiety disorder, they're actually very addictive. Mind you, so too is diazepam, which is, as far as I'm concerned, the treatment for Xanax dependence, but we'll learn more about that in another episode. So if we look specifically at substance use disorder and benzodiazepines, patients on long-term benzodiazepines are more likely to suffer from alcohol use disorder. And in fact, exceeding 1 standard drink per day is a more significant predictor of benzodiazepine withdrawal severity than the dose or the half-life of the benzodiazepine in question. So alcohol use or alcohol misuse goes hand in hand with benzodiazepine dependence. Patients on long-term benzodiazepines are also more likely to suffer from greater degrees of mental health comorbidity. So we're talking about more anxiety and more depression. And they're more likely to use illicit substances. And so, for instance, we know that benzodiazepines enhance the euphoria associated with the use of illicit opioids. So there is a close correlation between severe mental health disorders and various other types of addiction when we are considering benzodiazepine dependence or addiction per se. But it's not all bad news. I mean, benzodiazepines do have a place in our therapeutic armamentarium. And in particular, I would actually point out that benzodiazepines are first line for the management of alcohol withdrawal. So we use various types of benzodiazepines for alcohol withdrawal. So, we have the front loading regime where we have very high, large doses on day one in an inpatient setting and then no further benzodiazepines thereafter. We have tapering dose regimes. So we have predetermined fixed doses of benzodiazepines administered in reducing doses over 2 to 6 days. That's more commonly used in outpatient alcohol withdrawal treatment settings. And then we have what we call symptom-triggered sedation, where doses of benzodiazepines are administered according to the severity of withdrawal symptoms over a period of time. And those withdrawal symptoms are actually measured using various scales, such as the alcohol withdrawal scale, the AWS. So, is it safe to cease benzodiazepines after an alcohol withdrawal? If the patient has not had a pre-existing exposure to benzodiazepines in the long term and is not dependent on benzodiazepines, it is actually safe to suddenly cease the use of benzodiazepines within 1 month of use, especially in the context of alcohol withdrawal. So most alcohol withdrawal treatments with benzodiazepines are ceased within 5 to 7 days. So that's definitely within that month cutoff. Now, diazepam has a long half-life, as we already know, and therefore, diazepam, when you stop it suddenly, actually self-tapers. So in the context of alcohol withdrawal, it's very, very safe to stop suddenly after short-term use. Oxazepam is another commonly used benzodiazepine that is used for alcohol withdrawal associated with the risk of liver disease or benzodiazepine accumulation. And again, if you're using it for less than a month, and then remember in the context of an AWS-mediated withdrawal from alcohol, you're using it for no more than 5 to 7 days, it too is safe to cease suddenly. But note that because it's got a short half-life, there is no self-tapering effect. So my usual practice when I'm using oxazepam for alcohol withdrawal is to actually make sure that I'm continuing to prescribe oxazepam for at least 7 days, just to make sure that the alcohol withdrawal is totally finished before I cease oxazepam. Now, alcohol withdrawal in the context of long-term benzodiazepine use and misuse. So this is slightly different. So patients on long-term benzodiazepines, if it's prescribed and verifiably prescribed, need tapering of their baseline use. So really, we should be continuing their benzodiazepines after withdrawal from the level of their pre-existing use and then gradually tapering that onwards. Now, people who have got a history of illicit benzodiazepine dependency should be judged on the presence of withdrawal symptoms, or they should be treated according to the 40% rule. So really, if we're going to just go on withdrawal symptoms, what I would do is I expect to be using higher than expected doses of benzodiazepines during an alcohol withdrawal, and then I will reduce the dose of benzodiazepines according to patients' symptoms, and expect to then have to maintain a level of benzodiazepine use in the region of 20 to 40 milligrams a day. And then once the patient has been stabilized on that dose, then I would start tapering. The 40% rule comes from a line from the therapeutic guidelines. And they say it is usual practice, in inverted commas, to prescribe a maximum of 40% of the stated dose of illicit benzodiazepines, up to a maximum of 80 milligrams a day of diazepam equivalent. So, this idea then that if someone comes in and says they're using 100 milligrams of Xanax a day illicitly and they need an alcohol withdrawal, so they basically, the 40% rule would suggest that you would have to take a an 80 milligram dose of diazepam as their 40% rule, and then use that as their baseline. I tend not to use the 40% rule. I tend to use the presence of withdrawal symptoms to guide my dosing of benzodiazepines, especially after an alcohol withdrawal and certainly during the subsequent taper. Hopefully you'll understand from this discussion that it's not easy and it's more of an art than a science. And we can say that in general of tapering. So the issue then becomes, how do you actually successfully taper benzodiazepines? Irrespective of the previous context, if you have someone who you think needs to slowly reduce their benzodiazepines because they are dependent on benzodiazepines and they want to come off, how do you actually do that? The best way of doing it starts off with converting their benzodiazepine use to a benzodiazepine with the longest half-life. And for me, that is diazepam. And remember, benzodiazepines with long half-lives, such as diazepam, they cause a very smooth decline. So they self-taper on immediate cessation. So if you're trying to manage a taper, you want a very smooth descent. And diazepam will give that to you. Now remember, you can only really use diazepam if the patient has got normal phase 1 metabolism. Now, phase 1 metabolism refers to the liver's action of metabolism on benzodiazepines, where phase 1 is a transformative reaction and phase 2 is actually the addition of a soluble group. So most benzodiazepines undergo phase 1 metabolism, except temazepam, lorazepam, oxazepam. And so in patients with impaired phase 1 metabolism, such as those with liver disease or those who are elderly, if you use a drug that is dependent on phase 1 metabolism, such as diazepam, then you run the risk of accumulation. And that then has downstream effects on the risks of respiratory depression, et cetera, et cetera. So this idea of converting to diazepam only applies if you've got someone with a healthy liver who's not too old. When we're considering a conversion to diazepam, the maximum dose of diazepam I would use is 40 milligrams twice a day, i.e. 80 milligrams once a day. Now, at that point, you would then start considering a dose reduction. And according to South Australian Health, inpatient reduction speeds can be as high as 10 milligrams daily, so 5 milligrams twice a day dose reduction. I would suggest that you can do that as an inpatient, but only in cases where there is very high doses of benzodiazepines that are being used. As an outpatient, and I would suggest for moderate to low doses, you need a much, much slower speed of tapering. And 5 milligrams per week has been quoted as an appropriate taper. So too has 10% of the starting dose per week or fortnight. And the emphasis being that in a gradual community taper, the first half of the taper should be fairly plain sailing, less symptomatic than the second half. And so if you're engaging in a taper and you're now into the second half of the taper, you need to reduce the taper speed and also increase the taper interval, the interval between dose reductions. So you need to go much slower during the second half of any taper. But again, there is very little specific guidance on tapering, and it is an art rather than a science. And I would suggest that tapering speeds are negotiated with patients. You can always have a tapering holiday, but I wouldn't actually go back up a dose of benzodiazepines during a taper, but I'd be very happy to slow down or pause a taper if someone was struggling with symptoms of withdrawal from benzodiazepines. So to summarize, we've talked about the role of benzodiazepines in neurological function. We've talked about the role of benzodiazepines in substance use disorders, their addiction potential. We've discussed the role of benzodiazepines in alcohol withdrawal, and we've touched on tapering. That's all for today, folks. My name's Dr. Ferghal Armstrong, and this has been Cracking Addiction.